everyone's really right to be concerned about what's going to happen next, right? Because even within our own group, we have concerns about the ability to care for patients to do elective surgeries. I mean, truthfully, the census across the state is down such that I think Ohio's rightly concerned about cash on hand because we've canceled so many things and people aren't coming in. Our censuses are so low, and I say that from a multiple different hat perspective. Anita pointed out there are protesters. That voice is absolutely growing. I mean, that's the thing I hear most about questions from people. People say things like, well, if we don't have any more cases, wouldn't it make sense to open things up? And there is a state house, there are committees in the state house to try to look at opening them up, but the ones so far are certainly created with a slant and a view related to what that looks like. I think Bob alluded to the different models. I think unfortunately there was a little bit of a disservice because Ohio First was using a model that was based on theoretical context and a number of spread, which gave us cases that were way out of proportion with what we actually saw, and potentially could still have seen had we not done social distancing, but there were so many unknowns. And there were empiric models that looked at what actually happened in other places that didn't jive, and so there's been a lot of confusion on this. Obviously, Ohio adjusted that down a fair bit, but unfortunately, it still leaves like 97% of the population not having had the disease, unclear amounts of natural immunity, and so once we get over this peak, what we do next is critical. And so from a politics perspective, I think there is a ton of pressure for the governor, and there will be a ton of pressure from the House and Senate, I believe, to open up things. Ohio's jobless rates are super high, right? I think there's close to just under 1 million new jobless claims in the last month or two. So I think it's like 800,000. And we have a state of 11.5 million or 11.3 million people. So when you're talking about 1 million people now out of work, and everyone kind of still scared, I think it's a tough line to walk. What I have been answering and sort of talking through a little bit is that despite the death rate, so if you look at our case rate and our death rate, right, it really is reassuring and does underscore we have done an amazing job. We have about 5 or 6% new cases every day, but it's a 10 to 20 day disease, so we have 5 to 10% of people that recover every day. So it really is flat, but it's flat without actually developing immunity. So how we proceed is really critical. Most in models across different organizations that have looked at economic recovery models say that the key, both here and then internationally, right, like in South Korea, is to be able to test and trace all contacts. And so that's really a focus, is testing and being able to trace contacts so that you can really understand and quarantine appropriately. That's certainly not yet in place. The thing I do focus on with numbers and in a sort of staying in our lane type of approach, I've had a lot of people say, for a non-high risk patient, the death rate is low, and that is 100% true, right? 0 to 19, the death rate approaches 0, but 0 to 19, the hospitalization rate is still 0.2%. So if every kid in Ohio, right, got the disease, and we had a 0.2% hospitalization, it would still take us months of hospital capacity in order to care for those individuals. And if you start doing math, right, there's an 18% hospitalization rate from 20 to 44. There's a 25% hospitalization rate from 44 to 55. There's a 35% hospitalization rate from 55 to 64, and it goes way up after 65, right? And so if you're talking about 18 to 35% of the working age population getting sick and requiring hospitalization, both that overwhelms the healthcare system and the economy. And so that's sort of the messaging I approach, which is we can't just look at death rate, we have to look at the hospitalization rate, and then go back to the reason that the convention center and the prep is important is not because of exactly what we see now, but because we cannot exactly predict what we're going to see as we open up. And yeah, I do think that's going to be the major conversation, because people are feeling the economic burden, whether it's because they've lost their job, or they've lost their revenue, or they've had not been able to get back to work because they need that knee surgery to do it and it's considered elective. So let's say from what hat? Yeah, the Ohio House and generally large groups even in government are not meeting. Most of this is done through executive order, as everyone has seen. I do feel like there's a lot of good things about what has occurred in that perspective, in that way. And there is in the Ohio House an economic recovery group that has been meeting and has been instructed to give a report next week on how to get the state back open as quickly as possible. Again, I think that as much as I wouldn't like it to be messy in politics and it would all be on data and numbers and what's real for people, I don't think we're gonna escape that. There's certainly a lot of places where there are more rural representatives where there's almost no documented cases that are pushing very hard to open up things. So as much as the organization is comfortable, I think highlighting that, hospitalization and ICU is really something that happens a lot with this disease, that we still have to be smart and slow and cautious, is really a good idea. Let's see, we did get about $250 million federal dollars to help with some of the issues related to testing and hospital capacity and PPE. So hopefully that will make things a little bit less tight financially. We just purchased X number of ventilators, and I don't remember the number. I think it was like 2,000, and a ton of N95. So again, I think people are proceeding along the path that, although the models predicted different cases and the time frame is going to be off, we're still not immune. And until the vaccine comes, and hopefully this means a death blow to the anti-vax movement, that it's really going to be difficult. Can also speak a little bit as a hospitalist, because I'm a hospitalist at OSU. We have final approval for the surge plans that relate to our coverage of the convention center. I think they're being presented tomorrow, so I can absolutely reinforce what Bob had stated about all the hospital systems creating multi-level, multicolored responses, and we'll be 100% ready should this get back out of control. But yeah, what questions can I answer? I really do kind of spend my days studying these things because the State House is quite quiet, except for me trying to explain what's going on in terms of coronavirus and what the different masks are. And I'll say that I actually just created a little video on what the masks were that I'll push out, because I don't think people know what an N95 is. This is one that I was fit tested with, so it's not usable, but I can show it. So what is a PPE, to try to make sure that people really understand what we're talking about. And I actually think Anita's story on what's elective versus non-elective can help people understand the difficulties in those decisions, because sometimes they don't necessarily get the details that we have. Yeah.
Could you forward that mask promo video to Lisa so we can post? And Anita,
yeah.
Would you mind doing a quick vlog about a patient with a hemoglobin of 8 that you've had to transfuse and can't get done? So we start the discussion of elective surgery and urgent surgery, because I think a lot of people will chime in if we start and give them one example. As I said, people are not doing appendectomies. They're putting them on antibiotics and sending them home, which is a standard treatment in Europe and parts of the United States, but it's not what I grew up doing. So
right.
a lot of things are discussion.
Yeah, I'm happy to do that.
Yeah, absolutely.
This is Eric Drobny. I just want to just cut in for 1 second. I think there's a couple other issues that we probably could address. And patients are not coming in with with stuff right now. I mean, I've seen stroke presentations like 3 days after their stroke. We've seen some delayed MI patients. So it would be helpful if we could somehow get the message out to patients that, the hospitals are still open for the things that continue to happen, those emergencies. Please come in and get those taken care of. I suspect there's a fair amount of morbidity that we're going to see down the road from things that were just not done.
I absolutely agree, and that's my hospitalist hat says the people we're admitting are really sick because they're not coming in for, at the very beginning of the illness, they're waiting, and that's just my end of experience. It isn't any data beyond that, but I would agree, getting that message out. Call your doctor. Everyone's setting up these telehealth processes, so call your doctor.
Yeah, I will say